The title of my PhD is Harnessing the Potential of Digital Pain Self-Reporting Tools for Pain Assessment and Management. The pain assessment tool that we have been working on, that's called Manchester Digital Pain Mannequin. We have done several iterations to the tool just to make it fit for the purpose and for the people who are most in the need for pain management. We have looked at different disadvantaged groups who are more likely to have negative pain management outcomes because their pain is not managed within the clinical settings. Might be because of the reason they perceive pain differently, and they communicate and manage their pain differently because of their cultural background. Whenever we talk about or whenever we read about inclusive research for South Asian, language comes out to be the most common factor. Which is true, but that's not the only factor. Through this journey of engaging with multiple community members and community leaders, we have identified that working with community leaders is one of the very promising approach that can help researchers make their research more inclusive.
We are there to advocate for the community, serve for the community, make sure they're heard, listened, valued and understood. We've not been raised to air our laundry in the public, and it doesn't come to us naturally. This is how we've been raised. It's not a bad thing, it's a survival mechanism. And then when we met Baijan Mustafa, I call him Baijan, which means brother, when we met Mustafa and many other researchers similar to him, it was a special invitation, I think, to feel part of something which is bigger than us. I don't think we realise the passion that our researchers have to engage with us. It always felt like we don't matter, we are irrelevant. But to be asked, to be seen, to be heard, to be valued, gives us the dignity, gives us the respect that we actually do matter and we should be a part of this country's research.
It's not only the language barrier, which like I mentioned before, it is also the lack of trust, which cannot be addressed very quickly. And I think so the easiest way to build the system around it is working with community organizations or community-based organizations like mosques, like charitable organizations. These organizations are already there within the community. They have been working for so many years. People recognize them, people respect them, people listen to them, and people have trust and faith in them. And that's the main strength, that if we leverage it within our research, then we can make our research more inclusive.
It's people like yourselves and researchers who are going to be the missing pieces and help us to shape a new future where we matter and our lives matter and our health is our priority, which has never been presented to us like that. The traditional healthcare model is you go to the doctor, you do as the doctor says. You go to the elder, you do as the elder says. Never has anybody said to us, how do you feel? What do you think is the best course of action? When somebody dignifies us by asking us a question, it's allowing our community, those people who do not ordinarily engage with service providers or courses, or will go on to an online course, or will study and fill out forms. People value honest conversations, face-to-face, and human contact. A chat over a cup of tea is the most valuable insight you're going to get. And the other final thing I'd say, which is the most important thing when you do research, is come back and tell us what the outcomes are. Take time out, value us. You said, we did. This worked, this didn't. How can we figure it out? What should we do differently? What can we do next?